Welcome, Dr. Sachin Kulkarni, sir. And he's the. Can I have his slide,
Yes,
please?
yes.
Yes. He's a senior consultant at Sunanda IVF Kolhapur, and he's the head of the Department Fertility and Reproductive Medicine Department, Jahangir Hospital, Pune. He's a teacher at the Reproductive Medicine course at Dubai, and he's a consultant at New Life Fertility Center, Addis Ababa. And he regularly conducts fellowship program in IVF and reproductive medicine. Thank you for accepting this invite, and welcome, sir, for this talk. Over to you, sir,
Thank,
Dr. Sachin.
thank you, ma'am. Thank you so much. And we hardly appreciate and we are very much thankful to you for introducing our speaker for today. So I request Sachin sir to kindly start his session.
Yeah, namaste everybody, and thank you so much. Jayesh, I feel short of words of applauding you for conducting this whole series of webinars on fertility, and it has been such an enriching experience for each and every one of us. And I'm sure you'll continue to do your contributions in a great fashion to the academics of fertility and reproductive medicine in India. And kudos to you, and a lot of best wishes to do more and more and best and best. I'm unable to share the screen. Oh yeah, I can. Okay, today it's been a very beautiful topic which has been told to me to talk on is cost-effective IVF. And this is not just a strategy statement, but it is a moral imperative for all of us, all of us to perform IVF in such a fashion that it is cost-effective to the client in front of us. Uh, Affordable IVF is not with cutting corners or to create an illusion of success. And that's what we see commonly on the hoardings and advertisements. But we really want to ensure a genuine, evidence based chance to take a baby home. And that's what we are discussing today, this topic of cost effective IVF practice. A lot has changed since the birth of Louise Brown, and that's the thing which is in the London Museum kept, and that's the incubator where the embryo of Louise Brown was born. And this is almost up to 40 years. She's clicking a photo with that. And now we have time-lapse incubators and so much of technology infused. And definitely when you have so much of technology infused and so many upcoming prototypes and technology which is awaited here, definitely the costs are going to go up. So it is again very imperative for all of us to think twice, put only evidence-based practices in place so that we can give best chances to our patients. Now, one may ask, India is such a populous country, and why do we really want infertility treatments for so many? But there is always a bareness amidst the plenty. Just because the population is high does not free the country from infertility clients. And rather, when the population is so high and every other person is getting pregnant so fast, there is higher amount of stigmatization and there's also social isolation experienced by our infertility clients. There's also some of the women may have experienced existential crisis, like childbirth will guarantee them a stable marriage, inheritance rights, and social security at old age. For all these reasons, fertility treatments are so many women want to go ahead with fertility treatments. So in this presentation, we'd like to explore the science, the different systems, and the smart choices to get more and more affordability to us. There is always a compendium of willingness to pay by the client and cost of creating one live baby, and that will differ in different situations. At the end of the presentation, I'm going to put an interesting table to all of you that how it's going to be more, not I would say not confusing, more challenging to all of us to take decisions. We always see a healthy couple, and then we could give some treatments, and treatments may fail, more often so. And then after 2-3 treatment failures, down 1 year, this couple could be a distressed, depressed couple with obesity coming up or some problem therein. So we have to face all these long-term sadness, interruption of life plans, sense of loss of meaning, and stigmatization by all our patients are facing this. Again, the success of fertility treatment is judged by ability to create life, not by saving on something or extending a good health or improve the health related to quality, but it's basically preventing of psychological suffering of infertility. And that makes the insurance companies waver onto these kinds of treatments. And couple is actually buying hope to have a baby and a meaningful life later and it's not avoiding a disease. It has been a struggle to put to the insurance community that infertility disease. Only over last 1.5 decade, we have been successfully able to do that. So what could be the cost-effective measures? Pricing of the cycle, but then the pricing of the cycle we need to calculate till the live birth rate. And the couple commonly asks us, are you telling me the cost till the live birth, or are you just telling me the cost of the cycle? Even today, the clients are asking this. And are we looking at the pricing of the cycle with single embryo transfers or multiple embryo transfers? Then we need to clarify them the success at every step till ET, that the pricing of success of getting good quality eggs, making a good quality blastocyst, uh, achieving a good endometrium, and transferring the embryo. So every small success has to be evidence-based and should be planned in a cost-effective manner. And again, it's not just cost-effective, it has to be planned in the best evidence-based manner to benefit the client the most. Less time to pregnancy is one of the success parameters all of us are chasing. And again, most of our patients are middle class and they would like to have more embryo transfers per OPU. And we all understand that cumulative live birth rate per cycle is more important a success parameter to us than just live birth rate per OPU. So we need to discuss this with the client very clearly. Are we looking for one live birth or we are looking for a cumulative live birth? Even sometimes there could be looking for one live birth, but we ourselves, we are looking for a cumulative live birth because we understand the treatment has some failure rate. And because of failure, it is better to have more embryos to transfer so that in one go, they can have more chances of having one live birth, or some of them may be able to complete their families as well. Again, the couple has a finite budget of IVF. No add-ons are covered by insurance again. So we can't keep adding add-on treatments to the treatments. The cost effectiveness of add-on is clinic's responsibility, since the couple shall always say yes to any add-on you say because it's an emotional decision for them, but it's an evidence-based add-on for you. And that meaningful middle path has to be achieved by the clinician himself. So how we can contribute to this? So we can stop offering unnecessary IVF. So we need to have a very careful patient selection. And one of the problems here is 40% of the IVF cycles are offered to young, unexplained infertility of short duration. Maybe there's time for a year or two. And in the context of low AMH, just because you are low AMH. But believe me, no definition of unexplained infertility says that low AMH is a reason of infertility. If they are ovulating, her chance of fecundity rate and achieving pregnancy is the same. Investigation, we need to simplify them, cannot keep repeating the investigations. Medications, we need to reduce the cost of controlled ovarian stimulation, and lab equipment can we simplify our procedures. So repeated blood tests without any change in intention of treatment is something we need to ask ourselves before prescribing an investigation. Many times it's the fertility profile or infertility profile is prescribed. And again, vitamin B12s and vitamin Ds and so many investigations are just repeated again and again by clinic to clinic, which is not necessary. Simple light macroscopy semen analysis is the WHO standard, is the standard of care and not CASA. So there's no point putting CASA. Again, CASA is unable to make more diagnosis when the semen analysis or semen count, sperm count is less than 5 million. And we really need to wisely choose between laparoscopy and hysterosalpingography. So these are the things which we're going to discuss today. And all these things, each of them, before you embark onto IVF, you need to discuss each of them with the client. Not just the procedure of stimulation for so many days and pick up and this and that. We need to discuss each of them categorically to them so that we collectively take a shared decision making and a middle path can be established very well. So let's go into each of these stuff and understand what is the evidence and can cost control these parts. What about pre-treatment? There are two pre-treatments. One is given to improvise the egg quality. That could be coenzyme Qs and DHEAs, vitamin B12, folic acid, D, exercise, mindful practices, etc. And we need to do that for a certain amount of time. But then a lot of us do pre-treatment for better synchronization. The commonest pre-treatment offered is estradiol or agonist. And nowadays, with elagolix available, probably we may offer elagolix pre-treatment to a lot of our clients. But understand, with every kind of pre-treatment we offer, there is going to be a higher dose of stimulation and the stimulations can go longer. I feel estradiol pre-treatment has all the value and it could be uniformly applied because it's been practiced world over for the scheduling reasons all over Europe. Not only that, uniquely, estradiol pre-treatment offers LH to go up. And we need to embark our IVF stimulation with adequate pre-treatment LH pool. The simple thing is, if you have good LH, you will have good androstenedione. If you have good androstenedione, there is good estradiol, and obviously the oocyte number and oocyte quality will be better. A good LH would be anything between 2 to 10 MIU. And estrogen pretreatment guarantees that adequate LH pool to kick off the stimulation. What about stimulation protocol? Antagonist has become a standard of care for all of us. Antagonist protocol allows fresh embryo transfer. Elagolix could be a good cost cutting, because an elagolix maybe for 6 or 7 days would not cost you beyond 900 rupees, while each injection of antagonist is going to cost you that. So elagolix 150 or 200 milligram once a day could be a cost cutting antagonist to be used. What about PPOS? There have been multiple studies published on PPOS and whether it really cuts the cost, but FET becomes a must. So I really don't know whether doing PPOS with an FET really is a cost-cutting measure. Let's talk of mild stimulation. Mild stimulation or IVF basically was premised at minimizing embryonic aneuploidy. Robert Edwards kept on telling the world that moment you keep stimulating more and more, you're going to create more aneuploid embryos. But later on, we realized it is not the true story. So mild stimulation for minimizing embryonic aneuploidy just faded away over the last 1 decade. Low OHSS, but agonist trigger has completely abolished OHSS, and something which needs a Nobel Award in our IVF practice could be an agonist trigger, which has taken away all the fear of OHSS from us and from the clients. Well, mild stimulation could have low oocyte yield, and there would be more cancelled cycles. Number available for vitrification are small, so your cumulative live birth rate will suffer. So in any IVF, a completeness denotes one transferred embryo. A cycle cancellation reflects poorly on the clinic's performance and agonizing for the couple. Obviously, the client will not hold on to you, will change the clinic. So we need to complete a cycle by transferring one transferable embryo. So it is very important that cycle cancellation should be looked upon as a failure, because the client is looking towards it as a failure. And not only that, the client looks upon that as a clinic's failure. So mild stimulation is something which I don't promote or rather practice in my career. So if you want to do a mild stimulation, when will you give it? We have those patients who are young, who are good ovarian reserve, and they're high responders. What I mean by high responders is you're given a letrozole tablet, which is uniquely will have 1 egg, but suddenly this lady has 2 or 3 eggs. That means she's a high responder. If they are going for an IVF-HC for reasons like male factor or any other reason, then mild stimulation can be one thing which can be implemented there. But preferably no ICSI data here, because there's no TC. Because with TC, you could be putting aneuploidy therein. So mild stimulation, again, if you're doing TC, may not be the right way to go ahead. What about different drugs and the dosages we use? These are all the drugs choices we have to us, like we have RFSH, HPHMG like Menopure. I put it in the Indian HMG, so I just put it IND HMG, RFSH, RLH, RFSH and HPHMG, RFSH and Indian. These are the different combinations which all of us use in our practice. It feels very sad that we are keeping Indian HMG separate, because in spite of IVF existing in a country for the last 4 decades, we have not been able to give a consistently best HMG which can compete with an international brand like Menopure. I feel very sad about it, that we need to get the cost. We are able to get the cost down, but we're not giving the best of the HMGs from our sources. So what are the common determinants of dose? It's AMH, AFC, body mass index, and age. It is but when we decide on a protocol, it is our duty as a clinician that we must avoid Posidone 1 and 2. It will be stupid. At the end of this, you'll end up getting 7 eggs, and the client asks, why I got 7 eggs? And you say, well, in next cycle, I need to do all these changes. Why not do all those changes in the very first cycle? Most of the cases, we should be able to assure 2 sets of embryos, which will increase the cost effectiveness. Then again, more oocytes and more embryos and more cumulative live birth rate. It's something very well established in all our community. To avoid Posidone 1 and 2, we'll be starting with a high starting dose. We have to use a RFSH. We need some kind of an LH activity in the stimulation and a dual trigger. Additional 1 day of stimulation takes the herd beyond 18 millimeter, and that gives more number of oocytes. Even Seshunkara's presentation about 2 weeks back said the same thing. Progesterone on the trigger day higher, it is better number of oocytes. And it's a very interesting trial done, wherein they looked at the serum progesterone level. It affects the outcome of IVF with different ovarian response. This is a nice paper. Look at the effect of progesterone. So suppose you have a serum progesterone level 0.5 or a serum progesterone level 1.5 on the day of HCG trigger. When you have a higher serum progesterone on the day of HCG trigger, you will get more number and better oocytes and a better embryos. But sadly, it will have endometrial effects, and that's why your fresh embryo transfer is not possible. So if you're intending to do a fresh embryo transfer cycle, obviously you can't have one more day of stimulation, because your serum progesterone goes up. Suddenly there will be an exponential rise in the cost because you're going to introduce FET at that point. But if you're looking at just cumulative live birth rate and you're not planning a freeze-all policy, nothing wrong in putting 1 or 2 more days of stimulation, take the progesterone a little up, and probably you're reaching the pinnacle of folliculogenesis, and your egg quality and the egg number would be better. So if you want to practice this RFSH and LH and dual trigger and taking the stimulation for 12 days, how do we cut the cost? It's very difficult. No way one can cut the cost. But this is the truthful evidence-based practice. So I don't think we have much to do in the cost-cutting measures here. Look at the choice of drugs. We looked at RFSH and HPHMG. This is just a summary of all the trials conducted when they compared the RFSH to HPHMG, and every time RFSH has given more number of oocytes. Obviously, we understand more oocytes, more embryos, and more pregnancies later. So we need to avoid suboptimal or unexpected poor response. And this suboptimal response, unexpected poor response, avoiding posidone 1, one of the theory which has been suggested that you must have LH activity. LH, a good treatment pool is necessary, and a good LH activity through the stimulation is necessary. So LH is low through the stimulation, irrespective of the basal LH. The initial 5 days of stimulation, as the FSH action starts and the follicle grows till 12 millimeter, the follicle secretes gonadotrophin, GNSAF, gonadotrophin surge attenuating factor. Because of that, the LH drops. And then you start adding ANTA once the follicle touches 12 or 14 millimeter, and then the LH is kept down. So LH is low throughout the stimulation. So you are creating a low LH environment just because you are doing controlled ovarian stimulation. LH receptor polymorphism is about 60% in Indian population. This is our own study. I'm sure JH will agree to that. Again, a lot of our clients are beyond 35 years. If the client is beyond 35 years, they are androgen deficient, and they will need LH to have more androstenedione produced so that their stimulation goes on very well. Hypothyroidism, very common in India. With hypothyroidism, there is more TRH. With more TRH, it pumps the pituitary to tell more TSH, but at the same time, more prolactin. So hypothyroidism and hyperprolactinemia goes hand in hand. And this hyperprolactin can cause an LH deficiency. So if a hypothyroidism patient in front of you, you can't give RFSH alone. You'll have to add some amount of LH activity. Endometriosis, trust me, even studies done on mild or minimal endometriosis women have altered ileal secretion patterns. And that's why most of these mild minimal don't do very well with letrozole and clomiphene alone in their non-IVF cycles. You have to add gonadotrophins like HMG to have a better outcome. With obesity, there'll be high leptin, there'll be high insulin resistance, and both of them suppress LH secretion. So in these clinical scenarios, which is again a common part of the real world scenario in India, we need to have an LH activity in our stimulation. Behind the attractive price tags in IVF, like 60,000 mein IVF karna, there are sometimes compromises in transparency, quality, and completeness of care. One price fits all is a concept which is limited only for marketing of an industrialized IVF program. Reality is extremely different. This is one beautiful paper of a 30 years of experience they have put in of whether HCG or LH supplementation during ovarian stimulation improve clinical outcome. And they looked at again the same studies of using HPHMG versus recombinant FSH and look at the ongoing pregnancy rate. The moment you look at the ongoing pregnancy rate, they are better with the HPHMG compared to the recombinant FSH because HPHMG somehow is associated with better top quality embryos and better oocytes, though numerically low. So HPHMG has less oocyte, but has 2 to 5% higher pregnancy rate if fresh embryo transfer is done. And I would like to underline fresh ET. So if you're planning your client to undergo fresh ET, using HPHMG makes all the sense because it is going to keep your estrogen level within limits. And if the HCG level, which could be maybe between 5 to 7 IU through the stimulation, will give a good LH activity through the stimulation, and your egg quality will be better and a fresh ET pregnancy rates are better. long agonist, if you are using RFSH, has less pregnancy with fresh eating, because RFSH has a full throttle stimulation force onto the oocyte pools. Because of that, the estrogen at the end of the stimulation will be very high, and obviously chances of the progesterone being high also is more, and that's why fresh ET chances are a little less. HMG, though, there is low response due to low bioavailability and oxidative station of drug. So what is the reason? Because Indian HMG is rat bioassays. The rat metabolism is very different. On top of that, the oxidation of the drug can take place, and both of them, over a period of time, the bioavailability of the Indian HMG can come down. So you can say roughly 150 IU of RFSH could be 225 IU of HMG action. More profound stimulation in high responders with fresh ET affects results adversely in spite of equal euploid embryos. And that's why this is your study of hyperresponder patients done with HPHMG and RFSH. So we have a profound stimulation, which we prefer doing because we are looking at the CLBR, the fresh ET results could be affected. And in such a scenario, better to do a freeze-all. If possibility of fresh ET, please use HPHMG. If you're doing freeze-all, pre-decided, more the merrier. RFSH plus LH activity of your choice, HMG or RLH, and they can go ahead with the stimulation. A decade back, IVF success was around 25 to 30%. Now it has gone to about 40 to 50%. But the IUI success rate has unchanged over decades together. So when you have a patient with poor ovarian reserve plus unexplained infertility is a major indication whether we should do, we think, should we do an IUI or IVF? So let's look at some studies on this background. So this is a study which is done on live birth rate per in vitro fertilization cycle is higher, and the cumulative live birth by compared the IVF is better than intrauterine insemination cumulative live birth in Poseidon 3 group, which is young and low reserve. So this is a Poseidon 3 group. Unexplained infertility is confirmed by tubes of patent, normal semen, normal sexual function, and they only studied the first embryo transfer done. And they did mild agonist or ANTA in all protocols they were used in IVF. In IUI, it was done with letrozole, clomiphene, or RFS in this particular study. There were 7 IVF and 14 IUIs were cancelled because of no oocytes or no follicular growth. 33.3% per ET IVF cycles live birth rate in the first ET itself, while 11.3% live birth rate in IUI group after 4 cycles. So though she is young, we're tempted to go for IUI, but we need to discuss this with the client in detail and look at the IUI group. I've underlined something with red. In the cycle 1, the pregnancy, the takers are about 154. When it comes to cycle 4, look at the number of patients who opted for an IUI, just 6 cases. So dropout rates of IVF are high, and that's very accepted. But believe me, dropout rates at IUI are also high, and they will just leave your clinic. So it's better to have a shared decision-making with the client of Poseidon 3 that will we go for an IUI or an IVF, and good amount of counseling and a psychological support will be needed there. So they looked at the threshold. They put a threshold of pregnancy rate at 6 months and 12 months, and look at 6 months and 12 months, getting pregnancy with IVF was better than the IUI in the Poseidon 3 group. So IUI frequently is not addressed because we don't address a lot of problems with IUI. We just do it because it's cheaper. That's why it is prioritized, or maybe it is taken as a stepping stone to do an IVF later. But again, we don't discuss these things very clearly with our clients. OHSS today is more common with IUI because we are giving HCG triggers. Time to pregnancy is more. Psychologically, if you have 2 or 3 IUI failures, the client is going with a hope and a false cycle. And that frequency of that cycle is the patient able to digest. I always ask my clients, we're going to do an IUI, but are you ready to digest that 85% of the time you're not going to be successful? Are you okay with it? And say that, well, doctor, I'm okay. And we go with 1 more cycle of IUI. And if you're able to digest that, put your foot into IUI. Otherwise, I'm just creating a depressed couple in front of me. And obviously, work absentees will be more and more consistently over months together. So this is a very beautiful study. They looked at the long gonadotropin agonist, the short agonist versus antagonist regimens for poor responders undergoing IVF. And this is one question we are always perplexed with when a poor ovarian reserve patient comes in front of us. And they looked at a very homogeneous population. What I mean by that is they gave 300 IU in the first cycle. They obtained 3 or less oocytes, and only the patient less than 40 years were included. So they were all proven poor responders and test of the pudding is, is in eating it. So they had taken the first cycle and they got less than 3 oocytes. Our cycles cancelled with 300 IU were also included. And look at the age, about 36 to 37. Look at the oocytes obtained. Agonist long 4, agonist short 2, and this is antagonist number 3. AFC, look at the AFC, almost same. Total FSH, agonist long, look at that. About 5,540 IU of FSH or HMG. They use Menopure and RFSH in different protocols. Agonist short is less, while antagonist is the least. Look at the ongoing pregnancy rate, it's about 16.2. But this study was not powered to compare the pregnancy rate, so it looks attractive, but since the power was not there, I wouldn't comment much on that part of the story. But we need to put this in a practice that agonist short is something which we are not using much. But when you use long protocol for these patients, are you going to be ready to give more amount of doses? Obviously, the cost is going to go up. With antagonist, the cost of the cycle would come down. Again, in antagonist cycle, why don't you think of elagolix, 150 milligram OD, flexi-start. Let the LH be not over-suppressed. So if the LH on day 4, one study is clearly saying on the LH on day 6 of stimulation, if it is 4 IU, there's no point giving antagonists because you are over-suppressing the LH then, and the effect will be reflected in the outcome. So this could be an elagolix addition and replacement of the injectable antagonist could be a cost-cutting measure. 600 rupees of elagolix is 5,000 rupees of cetrorelix all through the cycle. And one may say, well, elagolix may not suppress LH effectively. But who wants a complete suppression? We want rather a good amount of LH activity. And that LH activity is going to produce androstenedione again and again, so that your machinery of aromatase enzyme induced by your stimulation is going to act effectively and use all that androstenedione. LH ceiling is not a concept during the stimulation cycle. LH ceiling is the concept at the start of the stimulation, that a certain high LH value demands higher dose of stimulation. But there is nothing like an LH ceiling through. The common example would be Menopure. If you're using Menopure in a stimulation, your HCG value will be something about 4 to 6. 1 IU of HCG is 7 IU of LH activity. So about 4 IU of HCG means you are maintaining an LH of 28 IU, and you still get good number of oocyte in your embryo transfers, and your pregnancy rates are better. And look at this particular study. They looked at the LH on the anti-start day and looked at the oocytes obtained. If the LH on anti-start day was high, more oocytes are obtained. They also looked at the LH on anti-start day and the blastocysts obtained. Again, that was all high. So many women with extreme poor reserve and advanced age combination may have a higher LH on day 5 or day 6 because the number of granulosa cell layers on their oocytes are less. Because they are less, they secrete less GNSAF and the LH still remains high even on day 6 of stimulation. Don't get scared. This LH is good. Just start your antagonist and you'll get good outcomes. What about high dose? Let's look at a few studies. This is one study which is highly quoted by Elena Labata, though it's a retrospective analysis of doing single euploid embryos obtained out of egg donation cycles and transferred and looked at the pregnancy rate. And they looked at the ovarian response and the amount of euploidy. Look at the graph, which is very clear. Higher the response, more euploid embryos are formed. So this is what is practiced by all of us. Now, this is another study. They looked at the cumulative dose of gonadotrophins for COH. They say it does not influence the odds of embryonic aneuploidy. But till the stimulation duration of day 12, the blastocyst aneuploidy was not influenced. With women having beyond 12 days of stimulation, there was a significant rise in dose-dependent manner in aneuploidy. But this was again at a younger age. When the age control was applied, I think they negated this particular problem. So more aneuploidy stimulation beyond 12 could be because of advanced age and decreased oocyte. This is combination. When they use clomiphene or macroflare, they got more aneuploid association. High E2 levels could be, this is a hypothesis put forth, that there would be more blastocyst multinucleation. Higher doses, there could be, because of higher doses, there will be more asynchrony. And HCG, at the trigger date, there could be a lot of eggs who's cytoplasmically immature, and they may result into more aneuploidy. And this is what it was said. But the thing is, all these studies are published on PCR and FISH and not NGS technology. So let's look at a study published on NGS technology. So these are the different 2 studies which are published on high dose of FSH and HMG that does not affect euploidy rate. And this is a study done on NGS platform. They looked at studies beyond 5,000 IU of gonadotrophins or beyond 1,000, beyond 10 days, etc. There was no effect on the euploid rate. So one can go high in search of more euploid embryos. Now, again, the cost, when the moment you think of going high, where is the cost effectiveness? Now, let me take permission of the august audience I'm facing to introduce this particular concept. Don't quote me on this at all. This is what we have been done for experimenting this with some of our patients after a thorough counseling and taking necessary consents. And most of them, these are our embryo pooling cycles. And we are using intradermal FSH with clomiphene, RFSH with clomiphene. And look, we'll generally go for AFC less than 4 in both the ovaries together. And we give clomiphene, 100 milligram for the first 5 days. On day 1, we give a 900 IU RFSH intradermally. Then the client comes on day 4 or day 5, we give another 600 IU. Then we obviously on every time they visit, we do all E2 LH progesterone. This is part of our study and we want to do an observation. That's why we're doing this test. I'm not recommending it. Please don't misunderstand me that I'm recommending something. I'm just I'm doing this. This is basically been put up because I want to be open for criticism. And we just keep every 3 days giving RFSH. Some patients need 3 doses, like or some patients need 4. If the LH goes beyond 7, then we add an elagolix tablet. And this is we borrowed this from this particular paper of extended injection intervals by intradermal administration. And this is very clear how an intradermal is given. There's nothing new about it. And we just looked at the preliminary data. This is a very preliminary data. I've just done about 15 cases, maybe a little more, but this is just a very preliminary data. I'm telling you that we have been able to get, but for one patient, a day 3 embryo. These are pooling cycles, as I told you. And I need to analyze this to come to any conclusion. But these are very poor responders. It's a cost-cutting strategy because I want to use RFSH. I want to have a LH activity. My clomiphene provides me the LH activity. My RFSH is very high dose. And again, the total dose comes very low. And hence my cost-cutting is there. And I'm able to do this cycle like a routine Indian HMG cycle. William Omelette in 2014 introduced a walking egg project in Africa. He said, we need to take IVF to the poor countries. And this was a lab he set up. And he said that we don't need to do an ICSI. We will do all tube cultures. And those tubes were not incubators. They were basically pre-gas tubes. And they just put with oocytes, 2,000 to 5,000 motile sperms were put on eggs. And he ran the walking egg project. Unfortunately, not many takers later developed. But this was one introduction of your cost-cutting IVF. He says IVF is possible otherwise. ICSI is only reserved for male factor. And this is a prospective study. They compared ICSI with IVF using this sibling oocyte study they did in particular thing, using the IVF in those tubes. And they said there's no difference in ongoing pregnancy rate and live birth rate. And ICSI will be only reserved for that. So what about laboratory changes? Now, we come in fashion to go ahead with microfluidic sperm separation because we want to take the DNA fragmentation out. Then can microfluidic sperm separation be included in the package itself rather than costing the patient more because you would like to give benefit to everybody? Then a lot of patients with severe oligospermia, TISA samples, we may have to use electively calcium ionophore media, occult active media. But can these two changes be introduced free of cost to our clients? Because not for their benefit, because for our benefit, because we want to have more embryos and more chances of pregnancy. What about sperm DNA fragmentation? A lot of people still use sperm chromatin dispersion method. And that says it's a high sperm DNA fragmentation, and they go for TISA. But sperm chromatin dispersion method is a very poor method of assessing sperm DNA fragmentation. The studies say, only one study published, that you should repeat it after 2 months. Only if it's consistently showing high DNA fragmentation, you could consider that significant. But so for sperm DNA fragmentation, we better use flow cytometry, and then why not just use microfluidic for everybody so we can avoid a few TISAs and go ahead? Avoid TISA for reasons of high sperm DNA fragmentation. So what about cost effective? What about embryo transfers? Cost effective analysis of freeze only or fresh embryo transfer in IVF in non-PCOS population. PCOS, we all do freeze on. So ongoing pregnancy rate in no PCOS woman was similar in fresh and frozen cycle, and that was detected in Wong et al. In 2018. So in presence of a corpus luteum, in fresh embryo transfer, vaginal progesterone with first uterine pass effect is sufficient. But in FET, with HRT cycle or artificial cycle without a corpus luteum, vaginal progesterone alone is not sufficient. Well, most of the trials done on vaginal progesterone alone, the European trials, they say that progesterone level less than 10 nanograms has low pregnancy rate. And many studies in this regard have been published. So in this particular, they looked at the cost effectiveness. Freeze-only group spent about 3,900 euros, while fresh transfer group spent about 3,500 euros. So there is a considerable unexpected cost rise moment you say freeze-all, and especially if you're doing an artificial cycle. If you're doing a freeze-all cycle and if you're doing a transfer, ovulatory FET is the best one. Now, again, if you have more blastocysts, good morphological blastocysts, think of single blastocyst transfer. That is the key to reduce cost. And I think Jayesh is proponent of a single good blastocyst transfer. I really salute him for this. And but then, if you have a single blastocyst transfer, you need to maintain a highest embryology quality, and also a KPIs of the lab should be checked and audited all the time. So what about embryo transfer technique? Nature will always prevail, always ovulatory. I would say ovulatory FET should replace HRT unless otherwise needed. Do whatever adjustments with your laboratory, make things available, because ovulatory FET is the best practice. One, cheaper. You have corpus luteum, perinatal outcomes better, miscarriages less, more pregnancies obtained. So we should be going for ovulatory FET, either true natural cycle, modified natural cycle, or stimulated cycle. But ovulatory FET is the best practice to do. High miscarriages with vaginal progesterone alone in FET, adding aqueous progesterone, taking the progesterone level high, will get similar LBF. But all these things are in your HRT FET. When you do an ovulatory FET, trust me, your progesterone levels are good. And it's a very natural way. Just a vaginal progesterone and dydrogesterone will suffice. Probably all injections can be avoided. Not only that, you can give an HCG injection on the day of embryo transfer, increasing the progesterone level further and supporting the pregnancy better. So what should be the future outcome? I think all of us are treating a couple. And we understand that our ethos as a clinician is to treat a couple and not women alone. But when it comes to clinic, somehow we concentrate too much on the women, and which is practically so, yes, because the women determine the pregnancy of the 80% of the times. The sperm contributes some and the uterus contributes for the rest of the pregnancies. So, but now, I don't know whether this is going to add to our confusion. But what I'm going to tell you now is going to add to our better understanding of the subject. And we're going to make it more interesting, a repeat reading of all this thing. And this modality, what I'm showing you, is the best modality to teach our fellows to the science of reproductive medicine. So put a couple. On the right side, all are your women, and this is only applicable for IVF and not applicable for a routine ovulation induction. And this is put forth a concept by Sandro Estevez. So on the left side is all your Poseidon 1, 2, 3, 4 groups, which you are very aware about. On the horizontal is your males. Your Aphrodite 1 is hypo male. Aphrodite 2, oligospermia with FSH-LH normal. Aphrodite 3, oligo with FSH-LH normal but testosterone low. Aphrodite 4, oligo, FSH high, LH high, and normal unexplained male. Let's look at, we have to join these dots. What is the combination we see? In spite of a कुंडली बिंडली सब देख के आते, लेकिन ऐसा combination कुछ तो सामने मिल जाता है. I'm sorry to say that. But look at the Poseidon 1. The Poseidon 1 is a normal responder, young lady, but her husband is an Aphrodite male, Aphrodite 1. So he's an hypogonadotrophic. We won't be treating her at all. He's just on folic acid and vitamin D, but we'll be concentrating everything on the husband of giving him HCG, HMG, and some expectant treatment to the wife. Let's come to the other one. Poseidon 3 lady with Aphrodite 4 husband, oligospermia. FSH is high. Wow, the FSH is high. This could be a few of them could be even non-obstructive azoospermias. So you will think of ICSI, you will think of micro TC, but then you are going to counsel of multiple cycles, but you're not going to counsel of PGTA because she's young. Poseidon 4 with an Aphrodite 3, so oligospermia, FSH normal, testosterone is low. Well, testosterone is low. Is the patient's intratesticular testosterone low? So let's do 17 OHP. Let's do AMH level. AMH beyond 4, that means his intratesticular testosterone is low. We might as well correct it. But again, how do we counsel? Well, we'll do an ICSI, but we'll be doing a pooling cycle because you are Poseidon 4 and less number of eggs. But yes, in spite of pooling, I would recommend PGTA. Well, this is going to be quite interesting as our years to come in our practice. And this is something we should look upon. And I request Jayesh, if it appeals to you, please take it forward in IFS forum to create more and more data on this combination. And this is something which each of us can contribute and debate and make reproductive medicine learning more interesting. Non-IVF treatment in the bargain are overlooked. Repeated ovulation, induction cycles of PCOS can give them a pregnancy. What you have to infuse is patience and saburi. And they can just see the lady in front of you is 22 years, a bad piece at 8 AMH. By 26 years, AMH will also drop down, her chance of pregnancy goes up. But can we counsel them that way? Multiple IUIs? Yes. Why stop at 3 IUIs? If she's a young lady, everything all normal, we can't recommend a few more IUIs. There are studies enough published on 6 and 12 IUIs, and there is a pregnancy. I'm sure there will be some takers on that. But if we keep counseling them to go for IVF, probably that could be wrong. So we need a more counseling and more amount of cognitive behavioral therapy to convince clients this way. A thorough endometriosis clearance. India is having such phenomenal endometriosis surgeons spread all over India. So if everybody is offering very good endometriosis clearance, trust me, they will achieve more spontaneous conception. But all these things get guided into IVF, but we should be more patient to achieve them pregnancies. But today it has become an enterprise outlook. Like most of the enterprises, the CEOs are asking their consultants how many IVF cycles are done in your clinic, but we don't ask each other also how many got pregnant last month for you. Those pregnancies could have been achieved of weight reduction or letrozole. How does it matter anyway? Our ethos is to get women pregnant and not completing an IVF cycle. So fertility treatments today are no more clinical care. It's an enterprise business. Add-ons are more access as a business models and marketing strategies than improved pregnancy rate. So in spite of evidence not being published, it's like a tortoise and a hare where you just start putting into practice without any evidence published. And clinicians are more asked on how much of your OPD is converted to IVF conversion than pregnancies. And most of us as a clinician have an attitude, ask me no questions later, madam. So we have done everything possible. And that's why we keep on doing add-ons and putting everything to the question so that we don't want to be answerable if the cycle fails. And this is a typical competitive word. But then we forget that we are practicing science. And it's not just only consensus-based medicine. We are also practicing value-based medicine. And what adds value to our patient care is patient education, shared decision makings at every step, and prioritizing the strategies, transparent communication, patient access to trusted care. Why they should go to some blog sites? We should give them sites to explore on web, and either write down what we should access and where to access from, so that they get a proper communication. And we ourselves also need to be more cost conscious. 22nd July in 2023, in The Economist, it came that more affordable IVF can deliver 1 billion babies a month than we are delivering 64,000 babies today. So, and in India, with so much of low egg reserve, why IFS and ISAR should take, I feel, social egg freezing as a big drive in India. It's very essential. It's for our own daughters and daughter-in-laws. They better freeze their eggs fast so that they can chase their careers and they can try out pregnancies at a later date. The government and insurance companies are not going to fund IVF unless we clinicians and embryologists provide a high success with a reasonable price without any complexities. Thank you so much. And thank you, Jayesh and team, IFS team, for allowing me to present this. Thank you very much.
Thank you so much, sir. It was such a wonderful lecture, so thought-provoking that it just can't be, we just can't thank you enough for this lecture. You discussed the novel protocol, the intradermal FSH, which was absolutely a new thing for every one of us. The pedigree chart the permutation combination chart you discussed, considering Aphrodite and then Poseidon altogether, was absolutely a novel thing for all of us. So thank you so much. Jayesh, sir, we may have input from you.
It's really a great lecture, doctor. We are talking in the morning and you make it wonderful. There are so many new things, and I took a lot of photograph of your slides. Let me tell you apparently on the behalf, right, like that. There are a lot of new things are there, and this is what I will love to know, something new things and learn from the good masters. And here you are. Thank you so much.
Thank you, Jayesh.
Akshay Mahapatra.